Hi, I'm Dr. Katie Azevedo, and welcome to this session on expanding your PBIS framework to include school mental health supports. For this session, I'd like to start out with our learning intentions and success criteria. So for this session, we are going to review the elements of MTSS and PBIS, so some acronyms there for you. MTSS stands for Multi-Tier Systems of Support, and PBIS stands for Positive Behavior Interventions and Supports. We're also going to identify the connection between schools and mental health supports. We will explore the comprehensive school mental health systems and embedding trauma-sensitive practices into that PBIS framework. As far as measuring our success, we'll use this criteria. I will be able to identify how to utilize a multi-tier framework to house trauma-sensitive practices and mental health supports. We're going to start off by talking about MTSS, multi-tier systems of support. But first I have a question for you. Which comes first? Do we have kids that struggle academically and that really leads to some bad behavior? Or do we have kids with challenging behaviors and they're unable to engage in instruction, and so we see some academic challenges? So question to think about for a minute here. Do you vote that students struggle academically leading to behavior problems as the initial issue, or students' inappropriate behavior leads to academic failures? For those of you that voted both, you're correct. So the chicken and the egg definitely cross the line together, and that leads us to MTSS. This is a preventative framework that we have borrowed from the medical field, and what it does is it really gives us a structure to intentionally place our evidence-based interventions, instructions, and supports. Notice on the left-hand side we see academic systems, and on the right-hand side we see behavior systems. And our goal is to really be intentional with what supports, academic and behavioral, do we provide to all students, what supports do we provide to some students in small groups, and then what supports do we provide that are very intensive instruction and intervention to individual students. We're going to watch a quick video here that will go in depth a little bit further.
Our goal is to create a sustainable and systematic continuum of support for all students, meeting each student where he or she is at. That brings us to the importance, or the why, behind the multi-tier system of support, MTSS. The MTSS system addresses academic, behavioral, and social and emotional learning in a fully integrated system of support. Here we are integrating our academic system, commonly referred to as response to intervention, or RTI, and our behavior system, leaning on the evidence-based framework of PBIS. This three-tiered prevention model allows us to work proactively. We are no longer waiting on students to fail in order to rush in with supports. In the green zone at Tier 1, also referred to as universal support, research-based curriculum is provided to all students. This is intended to meet the needs of 80 to 90% of our student population. Moving up to the yellow zone, Tier 2 supports are provided to small groups of students based on their need. Only 5 to 10% of our student population should be in need of Tier 2 supports. At the top of our pyramid in red is our Tier 3 zone. This is meant to represent the 1 to 5% of our student population in need of intense instruction and intervention provided one-on-one. It is important to keep in mind, we are not trying to rearrange students. We are working to intentionally rearrange the supports and routines of the school to best meet the needs of the students. It's not about changing kids, it's about changing the environment.
So that leads me to a question. I want you to think about your own context and think through, how has your district and schools worked to intentionally rearrange the supports and the routines of the school to best meet the needs of the student? I'll give you 2 minutes for that reflection. All right, here's another view of this framework. Some things to point out here. If you notice that tier 1, that green, that goes underneath the entire triangle. And then tier 2 and tier 3 are in addition to. So we want to remember that tier 2 supports, those done in small groups, and tier 3 supports done individualized, those are in addition to rather than instead of. So we really want to think about how are we being intentional. That leads us to positive behavioral interventions and supports, PBIS. With PBIS, our goal is to make schools more effective and equitable learning environments for all kids. And we really do that by building environments that are predictable, that are consistent, that are positive, and that are safe. So when we're talking about students that have a high ACE score, adverse childhood experiences, just imagine how important those 4 elements are to those kids: predictable, consistent, positive, and safe. I love this definition of PBIS. If you notice, it's not from PBIS.org. It's actually from the National Center for School Mental Health at the University of Maryland School of Medicine. So a very recent, up-to-date definition, and I think it really paints a clear picture of what positive behavioral interventions and supports is. So PBIS is an evidence-based 3-tiered framework for improving and integrating all of the data, the systems, and practices affecting student outcomes every day. It is a way to support everyone, especially students with disabilities or those at risk, to create the kinds of schools where all students are successful. PBIS isn't just a curriculum you purchase or something you learn during a one-day professional development training. It's a commitment to addressing student behavior through systems change. When implemented well, students achieve improved social and academic outcomes. And overall, adults feel more effective and efficient. So we'll talk a little bit more about what PBIS is. SWPBIS is school-wide positive behavior support, same thing, just a little dated. We can have 2 districts or 2 schools implementing PBIS, and it can look very different within each school. However, if those schools are implementing with fidelity, they're going to share 4 common core elements, and those elements are outcomes, practices, systems, and data. We're going to dive a little deeper into those 4.
With so many initiatives coming and going, school staff can easily suffer from initiative fatigue. So what makes PBIS any different? Let's take a look and find out. PBIS is a decision-making framework that helps schools improve the academic and behavior outcomes of their students. And it accomplishes this through the strategic use of evidence-based practices. PBIS first started in the early 1990s and has since grown into a worldwide movement. Currently, there are more than 26,000 schools implementing PBIS. Here in the United States alone, it is estimated that over 30% of our schools are implementing positive behavior supports. It is important to remember that PBIS is not a program, a specific intervention, or a scripted curriculum like a lot of people may think. PBIS is different. It is a framework constructed by a school-based leadership team. The framework is flexible, allowing it to be compatible with each school's unique culture and climate. As a result, PBIS systems will look very different from school to school. However, when implemented correctly, they will all share 4 common elements. These elements are outcomes, practices, data, and systems. Outcomes are academic and behavior targets that we want our students to reach. These outcomes are not only created and supported by educators, but also by families and students themselves. The outcomes we select as a community reflect what we feel is most important for our students to achieve. Practices are interventions and strategies that we use to help our students reach the identified outcomes. The practices we use are evidence-based and validated through peer-reviewed research. By focusing our efforts on practices that we know will work, we can better achieve our set goals. Data is the information we use to make informed decisions in our schools. The entire PBIS framework must be built on reliable and valid data that is easily accessible to everyone. When we use data effectively, we can identify patterns that are occurring and cater to the strengths and needs of our students. Finally, systems are support structures that are put in place to keep PBIS running smoothly. They include a leadership team to help oversee its implementation, as well as written policies and procedures and expectations to help guide faculty and staff. We must have durable systems in place so our efforts will remain sustainable for years to come. So here's the key takeaway. PBIS is more than just a set of behavioral strategies. By focusing on outcomes, practices, data, and systems, PBIS creates a consistent and effective framework that all faculty and staff can integrate successfully into their schools. Work with your team to integrate these 4 elements of PBIS into your school.
So when schools are implementing PBIS with fidelity, they regularly check the effectiveness of their practices. They pull from a continuum of evidence-based interventions to support student needs. They develop content expertise through coaching and ongoing professional development. They rely on teams to guide the implementation process. They use data to monitor student progress. They implement universal screening practices, that's on the behavior side. And they include community members and families to create culturally relevant practices. So here are some outcomes. If you're implementing PBIS with fidelity, according to research, you're going to see a reduction in problem behavior. With a reduction in problem behavior, the flip side of that is we're going to see more pro-social, acceptable behavior. We're going to see improved emotional regulation, improved academic achievement, improved perceptions of school safety, improved organizational health, and we're going to see a reduction in staff turnover. We're going to see improved teacher perception of academic effectiveness. So think for a minute, within your context, whether it's your school or your district, which one of these would have the largest impact? All right, let's shift gears to specific school mental health. In order to do that, I really think it's important that we're all working from a common language. So here's how I'm defining mental health. And notice this is from Maryland School of Medicine. Mental health is the social, emotional, and behavioral well-being of students. I love that they include behavior. SEL is a very hot ticket item right now, social emotional learning. But it's really, really impossible to talk about social and emotional learning without also talking about behavior. So here we're including all 3. So mental health, one more time, the social, emotional, and behavior well-being of students. Mental health services are then defined as broadly defined as any activities, services, and supports that address social, emotional, and behavioral well-being of students. And this includes substance use, also from Maryland School of Medicine. So when we're talking about schools and we're talking about mental health, what's the connection here? I'm going to give you just 60 seconds to think through that. So let's continue on with the connection between schools and mental health supports. In 2007, the U.S. Surgeon General reported that 20% of children and youth were in need of some mental health intervention, but only a third of those in need received support. Of those that receive support, 70% access support through the school setting, leading many to declare schools as the de facto mental health setting for children. So why schools? We know that we want to meet kids where they're at, and that's typically schools. So we want to start where we know we can have the most impact, and for most of us, that's schools. Schools are one of our most structured, predictable, safe, preventative, continuous social support systems. And with the collaboration of school staff, families, and mental health clinicians, we can increase the access of care, enhance preventative services, and reduce the stigma of treatment. So I want to show a quick video here. These are the outcomes of a comprehensive school mental health system. So comprehensive meaning that we're including all the necessary people. We're thinking about the school structure, we're thinking about external clinicians, we're thinking about the students, we're thinking about parents, community members, and additional stakeholders. So once we get everyone on board into a universal framework, here are the outcomes.
Many positive outcomes have been evidenced in the status of children and adolescents who have participated in a comprehensive school mental health system. So a few of those outcomes are listed here. When we have children who are receiving mental health support within school systems, we are finding better academic outcomes, access to care, early identification and intervention, positive school climate and safety. We're seeing youth, family, educator, and peer engagement, and a continuum of services. We're also finding better psychosocial outcomes.
So those are some pretty powerful outcomes once we're doing it correctly. So this is what we know. Schools have an imperative to attend not just to the academic success of students, but to their social, emotional, and behavior development as well. Schools are a natural and logical setting in which to employ a public health framework that focuses on promoting student well-being and healthy behaviors and preventing mental health problems before they occur. But we know schools cannot do it alone. So here's a question for you. Knowing schools can't do it alone, who else needs to be involved to foster student well-being, healthy behaviors, and to prevent mental health issues? I'll give you 60 seconds to think through this. So many of you may have thought of the need as far as external clinicians and mental health experts. Absolutely. So that brings us to school mental health supports, which is not new. We've had external outside agencies and providers, clinicians coming into our schools for several years and supporting those kids. And so knowing that this has been going on for quite a while, what's the disconnect? So let's look at a few points of data here. We know that 13 to 20%, that's percentage of U.S. children who meet the criteria for a mental health disorder each year. Okay, we know 5%, that's a percentage of U.S. adolescents who meet criteria for a substance abuse disorder each year. And 12% percentage of these youth who receive any services to address the mental health and or substance abuse concerns. So if only 12% of our kids in need are receiving supports, there's some disconnect. That leads me to another question for reflection. Brainstorm possible limitations for supporting the mental health needs of all students. What are some limitations for schools who are already implementing PBIS and providing mental health supports on campus? All right, let's look at some of the documented shortcomings. So, shortcomings of PBIS. Schools often lacking a comprehensive, universal approach struggle to meet the mental health needs of children and adolescents. We know that it can take a long time to get Tier 2 supports up and running. We also have seen schools that struggle to establish Tier 3 systems and expertise for students with higher level needs. And an emphasis on externalizing behavior while often overlooking more internalizing behavior. So yes, of course, we know the students who are struggling and we see those through those externalizing behaviors, but we're not always aware of those that are showing more the internalizing behaviors. Now, shortcomings of mental health services. Mental health providers tend to operate separately from school staff. I can think about being a classroom teacher and having a clinician pull one of my students. I didn't really know what was happening within those sessions or how to best support it within my classroom. So that disconnect. Services are typically reactive rather than preventative. Lacking active participation of school staff. Lacking structured teaming, which can result in inconsistent use of evidence-based practices. So how often are they working together to collaborate and to team and problem solve? And then finally, systemic progress monitoring is absent. So just receiving services isn't enough. We want to check to see what are the outcomes of those services. I really love this visual. Please ignore the colors because I know I've been telling you Tier 1 is green and Tier 2 is yellow and Tier 3 is red. But I want you to look at that community partner. So if we think about our external clinicians that are coming in from different community providers, this is a great visual where, yeah, they're spending most of their expertise and their time at Tier 3 working with individual kids, but they can also greatly influence our Tier 2 practices, even our school-wide practices at Tier 1. So just a nice visual here. I want to talk briefly about what Idaho administrators are saying. So this information is coming from the Student Behavioral Health Services Evaluation Report. So a key takeaway, while nearly 60% of districts indicate they have a strategy or practice that is implemented to support all students, Only 1 in 4, that's 25% of school districts, reported having explicit structured programs available to all students. So what does that tell me? Tier 1 has not been established in 75% of our system, schools, organizations, LEAs. Another key takeaway, most common barriers, and this won't be a shocker, reported to behavioral health and wellness services were a lack of adequate time and funding. And then finally, rural respondents were 19% more likely to report that their district didn't have specific district level policies for implementing these supports, and 17% more likely to report their district didn't provide professional development around these areas. So if we're asking our adults in the building to provide the social, emotional, and behavior support, we also need to help build their capacity, give them the tools to do so. Good news is the benefits of behavioral health services were widely agreed upon, with more than 90% of administrators agreeing that they help students feel safe, ready to engage in learning, build stronger student-to-teacher relationships, promote better academic learning, build student engagement in schools, and are flexible to support unique students' needs. So I don't think there's anyone really out there, or maybe a few, that disagree with the importance of these mental health supports. So, what do we need? We need an interconnected systems framework. So current rates of mental illness, substance misuse, and opioid abuse are alarming and require societal shifts. Mental health prevention is now recognized as a critical part of education, but schools struggle with how to establish a comprehensive system of mental health support. The interconnected systems framework is an emerging approach for building a single system to address mental health and social emotional well-being in schools. So there's a lot of research out here on ISF, Interconnected Systems Framework, and it allows it allows schools to identify students with mental health needs earlier, link these students to evidence-based interventions, use data to ensure students receiving support improve, expand the role of clinicians to support school personnel and students at every tier, back to that triangle, and create healthier schools. So here are the 4 elements of ISF. A single system of support. All students need access to mental health support. Access is not enough. Students' impact defines success. And finally, core features of MTSS. Now we're going to go into depth on what each of these elements mean.
Current rates of mental illness and substance abuse are alarming and require societal shifts. Mental health prevention is now recognized as a crucial part of education, but schools struggle with how to establish a comprehensive system of mental health support. What we need is an interconnected system that leverages all of the available resources. This brings us to the Interconnected Systems Framework, or ISF. ISF systematically joins together the practices of PBIS and school mental health into a single system of support. Rather than doing one more thing or adding on something new, the ISF utilizes the already established framework of MTSS and PBIS and expands and enhances that framework to include school mental health supports. Using an interconnected systems framework allows schools to identify students with mental health needs earlier, link students to evidence-based interventions, use data to ensure students receiving support improve, expand the role for clinicians to support school personnel and students at every tier, and create healthier school environments. There are 4 foundational elements of the interconnected system framework. A single system of delivery is one in which education and mental health systems are integrated across tiers of support, with multidisciplinary teams using data to implement one continuum of evidence-based practices. Within a mental health for all approach, student social, emotional, and behavioral health is addressed with the same level of attention and concern as cognitive development and academic achievement. This results in social, emotional, behavioral skills being taught by all staff across all settings with all students and embedded in all curricula. Historically, school mental health programs have focused on counting the number of students referred to mental health providers, considering the number of students receiving a service as a measure of effectiveness. With the ISF, success is measured by tracking the fidelity of implementation and by monitoring the positive outcomes for students and their families. MTSS is essential to install school mental health supports. The ISF uses the features of MTSS as successfully applied through PBIS implementation over the past 2 decades. These features include a leadership team comprised of all stakeholders, a continuum of evidence-based interventions linked across all tiers, a formal process for selecting and implementing evidence-based practices. This interconnected system framework helps educators and clinicians to work smarter, not harder. It provides a structure to house our evidence-based practices.
Now let's talk specific about childhood trauma. So in relation to childhood trauma, there's some things we need. We need a system that provides accurate information about the prevalence and the impact of trauma. We need coaching and training around trauma response, and we need a clear understanding of our role in supporting students who've experienced trauma. So again, starting with the common language, trauma refers to extreme or chronic stress that overwhelms a person's ability to cope and results in feelings of vulnerability, helplessness, and fear. So that's a big can of worms when we're trying to define what trauma is. We're talking human behavior here though, so it's never going to be black and white, but we do want to clarify. So here's some clarifying points. It's not the event, it's the impact of the event. And let's skip down to the third one. Experience is subjective and difficult to assess. So 2 people may go through the exact same experience, and one may feel or may be impacted traumatically where the other one isn't. So again, it's subjective. Events may be witnessed or experienced directly. It often interferes with relationships, self-regulation, and fundamental beliefs about oneself, others, and one's place in the world. Just a nice reminder, children are like wet cement. Whatever falls on them makes an impression. So some facts on the prevalence of trauma. Nearly 35 million U.S. children have experienced at least one type of childhood trauma. Notice that's from 10 years ago. One study of younger children ages 2 to 5 found that 52% had experienced a severe stressor in their lifetime. A report of child abuse is made every 10 seconds, and in 2010, suicide was the second leading cause of death among children ages 12 to 17. I left that fact in there from 2010 because it's the same today. So today, suicide is still the second leading cause of death among children. When we're thinking about the impact, we know that children who have experienced ongoing trauma may have different reactions. Some children may develop an expectation that bad things will happen to them. Some may have a hard time forming relationships with other people. Some may have difficulty managing or regulating feelings and behavior. Some may have difficulty developing a positive sense of themselves. So thinking about the youth that you work with, have you seen any of these examples pop up? ACEs is adverse childhood experiences. This is the initial ACE list. So in that initial study where they were looking at how do factors early in life impact you later in life, they narrowed it down to these experiences: substance abuse in the home, parental separation or divorce, mental illness in the home, witnessing domestic violence, suicidal household member, death of a parent or another loved one, maybe their parents in jail or in prison, experience of abuse that could be psychological, physical, or sexual, or neglect, and that neglect could be emotional or physical. So knowing that those are kind of the factors, I'd like to show this video on the impact. So adverse childhood experiences, how does it impact us?
A child's experiences early in life are important building blocks for the developing brain. Genes, nature, are like the blueprint. They provide the basic framework for brain development. However, genes do not design the brain completely. Environmental influences, nurture, fine-tune how the brain works by shaping which brain connections get used. Connections that are used more grow stronger and more permanent, whereas ones that do not get much use fade away. Together, genes and the environment build the foundation for all future development. Safe, stable, and nurturing relationships early in life lead to healthy development. But children's brains capture other experiences as well. Stressful events. However, not all stress is bad. Positive stress involves normal childhood experiences, like starting daycare or meeting a new person for the first time. This stress is essential for healthy development because it helps children develop coping skills and confidence. But when stress is frequent, chronic, and uncontrolled, it is toxic to children, especially when they do not have a caregiver to provide support or buffer the stress. Adverse childhood experiences, ACEs, such as abuse, neglect, exposure to intimate partner violence, parental depression or addiction, and poverty, are toxic stressors which could lead to lifelong changes in learning and behavior. ACEs early in development can impact social, emotional, and cognitive functioning, increased risk-taking behavior such as drinking and substance use, and increased risk of disease, disability, and social problems later in life. The question is, how do adverse childhood experiences impact a lifelong development? One of the most important systems in our body is our stress system. It's activated when we experience stress. We become alert, our heart rate increases, and so do our stress hormone levels, cortisol and adrenaline. Our body is ready to react, what is known as fight or flight. A short period of time after the stress is over, or if a child receives support from a caregiver, the stress response turns off and the body returns to a normal state. Adverse childhood experiences create stress responses that stay active, and without the support of a caregiver, the system has difficulty shutting off completely. This constant and prolonged activation can affect immune system functioning and increase the chances of sickness, infection, and disease. Prolonged activation of stress hormones is also toxic to the brain. Certain areas of the brain are more vulnerable to toxic stress, including the executive center or the brain's control center, an area important for solving complex problems, attention, reasoning, impulsivity, inhibition, and learning. A second area is the emotional center, the brain's alarm system, which is involved in processing and interpreting emotions and the ability to control impulses. The third area is the memory and learning center, the brain's filing cabinet, which plays a major role in learning and the formation and retrieval of memories. Science shows that adverse childhood experiences impact all of these brain centers. Behaviorally, what we begin to see is emotional distress, poor emotion regulation, greater impulsivity, learning difficulties, and physical and mental health problems. More recently, science has begun to look at how ACEs cause changes in gene expression through a process called epigenetics, which helps us understand how nature and nurture interact. Epigenetics causes changes in the way genes work without changing the DNA code itself. This occurs through chemical changes influencing how the code is used. In other words, genes are like the hardware in a computer. They determine the boundaries of what is possible. However, we need an operating system to tell the hardware what to do. Epigenetics is like the operating system directing the function of a gene's DNA hardware. The genes we are born with are the genes that we have for life, but experiences like nutrition, exercise, smoking, stressors, and relationships all affect our biology. Adverse childhood experiences are associated with epigenetic changes related to stress, brain development, cognition, and systems associated with mental and physical health. Changes that happen early in brain development are more likely to be enduring and are possibly passed on to future generations as well. The good news is that positive, supportive relationships at any stage in life can make a difference. However, supporting families and children early on will help prevent many of these negative outcomes. One of the key ingredients for healthy development is having warm, loving, and actively engaged caregivers. This involves promoting serve and return interactions, where caregivers actively and warmly engage with the child, making eye contact, responding to sounds, words, gestures, emotional needs, and sharing experiences like reading and play. Providing programs that support caregivers to strengthen these abilities are the blocks that build healthy foundations for life.
So knowing those outcomes or that impact, I want us to think specifically to the business we're in, and that's the business of learning. So we know that adverse childhood experiences can adversely affect students' ability to acquire language and communication skills, take another person's perspective, attend a classroom instruction, regulate emotions, engage the curriculum, and utilize executive functions like making plans, organizing work, and following classroom rules. So essentially all those things that we need our students to come with, those skills to come to school with, they're going to be adversely affected through traumatic experiences. So here are some fundamental truths. Number one, trauma is real. Number two, trauma is prevalent. In fact, it is likely much more common than we care to admit. Number three, trauma is toxic to the brain and can affect development and learning in a multitude of ways. Number four, in our schools, we need to be prepared to support students who've experienced trauma, even if we don't know exactly who they are. So it's not necessary to know which students have which ACE score or what they've been through as far as specifics. Most of us aren't trained to deal with that information, but we do need to know that it's prevalent and to set up those environments that are consistent, predictable, safe, and positive. And finally, number five, children are resilient, and within positive learning environments, they can grow, learn, and succeed. This is one of my favorite quotes from Sowers and Hall. Because we know childhood trauma is real and prevalent, we really don't know which of our students have experienced an adverse event. It is our obligation to create a culture of safety, a safe, consistent, and predictable nest for every child under our care. So with that, I'd like to define what trauma-informed is. So this is coming to us from SAMHSA. So a trauma-informed approach is a program, organization, or system that is trauma-informed, realizes the widespread potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved within the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So knowing that, think about your organization, your system. Is it truly trauma-informed? Has this information been spread? Has the capacity of staff been built? And how has it emerged in your policies, your procedures, and your practices? My goal, though, is really to work smarter, not harder. So let's think about what do we already have in place and how can we embed some of these trauma-informed practices into our already established framework. So that really leads us back to multi-tier system of support, or PBIS. So how can we utilize those 3 tiers of support and embed our evidence-based trauma-informed practices? So think about, as far as trauma-informed practices go, what can we do for all kids? What can we do for some kids in small groups? And what can we do individualized for those kids that really need a lot of expertise? We also know that PBIS and trauma-informed practices fit together for several reasons. One, they overlap as they are grounded in similar science. Establishing a learning environment that is predictable, consistent, positive, safe, and equitable are crucial components to helping to heal students who've experienced trauma. And when trauma-informed practices become part of a multi-tier continuum of support, they benefit from the structures that contribute to efficiency and effectiveness. So rather than doing just one more thing, let's take what we already have and emphasize it to be trauma-informed. Now, I really like examples. I mean, theory is great, but really show me what that looks like. So here's a great example of a PBIS Tier 1 practice. This is a school-wide behavior matrix, teaching matrix. It's a pretend high school, the William High School way. And this high school has defined their 3 expectations or values or norms as far as behavior is concerned: respectful, organized and achieving, and responsible. And then they've thought, the staff has come together to create this document, and they've thought about the different contexts within their school. So they thought about, how do those 3 expectations play out in the classroom during the welcoming, the initial bell ringer, during group work, and then also online. So you can see here in the classroom, you're going to show respect by raising your hand, tracking the speaker, following directions. The beauty of this is we're no longer assuming that kids know what is appropriate versus inappropriate. We're explicitly teaching the behavior just like we explicitly teach academic content areas. And how nice would this be for a substitute teacher to walk in to a classroom or a school and on one page know what should I be seeing? What are the behaviors that I should be seeing? Now we can take this really simple Tier 1 practice and we can add to it to make it trauma informed. So here I've added when I feel upset. So I'm going to show respect when I feel upset by asking for a break, expressing feelings by making I statements. I'm going to be organized and achieving when I feel upset by asking my teacher to break down the assignment into smaller chunks. Talk to someone if it will make you feel better. So the important thing here is that we are teaching students the appropriate behaviors before they feel upset. And then they have the capacity to deal with them. So again, taking a super simple Tier 1 practice, adding to it, and we're now becoming trauma informed. We could beef this up a little bit more by adding this row. So this is the teacher's role, conditions for learning. So in the classroom, I am going to supervise all areas of the classroom. During the welcome, I'm going to greet students, post bell-to-bell activity. You can read the rest for yourself. But I do want to point out those things in bold, so bold font, those are specific evidence-based trauma-informed practices. So again, taking something that we may already have going with Fidelity, like PBIS, adding to it to be trauma-informed. All right, so I want to just think through a few questions. So no matter your role, these are some great questions for you. So if we're thinking about our multi-tier system of support, or PBIS, here are the core features: leadership teams, use of data, ensuring early access, a formal process for selecting interventions, measuring fidelity and outcomes, ongoing professional development and coaching. So think about your organization. Do district and school-based teams include an individual who has knowledge and expertise and the ability to provide coaching, support about the impact of trauma? Next element, do all staff know what data sources to use to determine which trauma-informed interventions are needed at which tier? And is community data and student and family perception data used to provide cultural context? Ensuring early access. So does the team use a formal process to identify children and youth needing additional support? And does the team review community neighborhood data to determine the magnitude of needs? Does the team use a formal process to select trauma-informed evidence-based practices and determine if they are implemented effectively? And when trauma-informed practices are added to the menu of available supports, does the team use the progress monitoring system to inform fidelity, effectiveness, and to guide improvement of implementation? And finally, ongoing professional development and coaching. Does the district plan include opportunities for staff to learn about trauma, its impact on youth, and the evidence-based practices that will be integrated across tiers? And what types of supports are available for staff who've experienced trauma or are experiencing secondary trauma? So just some food for thought there. These are a list of kind of my go-to books. It's not all of them, but it's a few of them, and I just wanted to share these with you. If you're interested in doing a book study within your school, your district, your organization, these are some great ones to start with. Reminder before we leave today, Our goal is to make schools more effective and equitable learning environments for all kids, and we do that by creating environments that are predictable, that are consistent, positive, and safe. So I'd like to circle back to our learning intentions and success criteria. Participants will review the elements of MTSS and PBIS. We identified the connection between schools and mental health supports. We explored comprehensive school mental health systems and embedding trauma-sensitive practices into a PBIS framework. Now, thumbs up, thumbs down. I am able to identify how to utilize a multi-tiered framework to house trauma-sensitive practices and mental health supports. Thank you for your time today. If you have additional questions or would like additional resources or professional learning activities or trainings, please contact me, Katie at kayazevedo.com. My website is kayazevedo.com and resultslearningcenter.com. Thank you for your time today.